A very warm welcome to part 3 of my presentation in a series of 5, and I will discuss with you the transmission of the virus. The spread of the virus takes place via droplets and aerosols. And there has been a huge confusion about this, and that is related to the fact that there is a very artificial separation. If the droplets are smaller than 5 micrometer, they are called aerosol, and if they are bigger, they are called droplets. And this is, of course, a very artificial separation. There will be not very much difference between a droplet of 4.9 micrometers versus 5.1. And it's also very easy that the bigger the droplets are, the quicker they will fall, and the smaller they are, the more that they will float. And the smaller they are, the less virus can be present in it, and the bigger, the more virus will be present in these droplets. So if you would like to have a look at this picture, you can see here what happens in the event of sneezing. And as you can see, there is a large amount of large droplets that will fall to the floor, but will remain quite present over a long distance. You see on the x-axis, you see the distance in meters, and there is also a turbulent gas cloud predominantly with aerosols. What happens in the event of coughing is indicated here, where you can see there are also large droplets, but they do not come as far as in the event of sneezing. And finally, in the event of exhaling, you can see that the exhaled air is predominantly with aerosols, and there are also some large droplets which will fall within 1 meter to the floor. But this will of course depend on many other situations, like how much wind there is at that specific moment, etc. Now, factors that play a role in transmission is to realize that viruses are in the droplets and the aerosol. And they are floating with the droplets and the aerosol. And there are less viruses in an aerosol, but on the other hand, aerosols get deeper into the lungs. So if you inhale an aerosol, and in each small droplet of this aerosol is a virus present, you will have a lot of viruses immediately in your lungs, and especially if you stay for a long time within this aerosol. Therefore, it's important to realize that factors like air humidity, temperature, sunlight, and ventilation also play a role. If the air is very humid, then the aerosol will be longer intact, and the virus can survive, if I may say so, longer in these aerosols. Whereas sunlight is very bad for the virus and therefore good for us. The viral load, the number of viruses in these particular droplets, and the exposure time, how long you inhale these droplets, also play an important role. So in such a way, it's easy to understand that you can have spreaders who cough or sing, who give a speech or sneeze, and you remember all these kind of spreaders who wetten your glasses, or where you feel the small droplets coming on your face when you talk to them. And these are, when they are contaminated with the virus, so-called super spreaders. And in this respect, Sneezy that you see here is, when he is contaminated, very likely to be a super spreader. So things are not really dichotomous. And we always speak about probabilities. And as you can imagine, if you have social distancing and you have 30 meters as social distancing, then it's very unlikely that you get contaminated by someone who has COVID-19. And if it is 10 meters, it is even still very unlikely, unless there is, for instance, a good wind that brings all the aerosols in your direction. and that compared to 1 meter. And you have big spreaders, little spreaders, and you have no spreaders, and it all depends on the number of the viruses. And do you have a high ventilation, or is there no ventilation at all in the rooms, the space where you find yourself, etc. The prevention is in fact very simple, is that you try to prevent viral spread. So you can limit the number of spreaders, you can introduce the biggest possible social distancing, limit the existence of aerosols and droplets, and if they are there, to ventilate them very quickly, that they get away from spaces where people are. Now, the personal protection equipment, PPE, is in fact taking care of that. It prevents the virus entering the mucosa. As I have shown and demonstrated in my first presentation, is you could see how the virus enters your body, and the personal protection equipment will prevent the virus entering the mucosa of the mouth, the nose, or the eyes. And different measures have been taken in different ICUs and in different countries, as you can see here. So that makes it very confusing for individual healthcare workers to know what is best. The most important is, of course, the face mask with the glasses, the gloves, and the gown. There is a lot of talking about the face masks, and I will explain it very clearly to you. It is not really rocket science at all. Now, the worst face mask is, of course, a totally porous face mask that will not filter the air at all. So it's very easy to breathe through this mask, but it will not offer any protection. And the best face mask protection is, of course, when there is no air passage at all. So if you use such a plastic a sac as a mask, it will protect you from getting contaminated, but you will be unable to breathe because there is no air passage at all. So do not try this, of course, but it's just to make clear how the difference is. So you really need a good balance. And it was before the COVID-19 pandemic decided that for such situations we would need an FFP2 mask, which filters about 95%. And FFP2 is also called N95 or KN95 in China. And we also know FFP3, which has a higher percentage of filtering, 99%. But it makes, of course, breathing a little bit more difficult. This is a table showing you the properties of the different masks. And you can recognize the different masks by the elastic band, whether it is yellow, blue or white or red. What about face masks in public space? Well, an important thing about face mask, it prevents people from touching their nose and mouth, because normally you touch several dozens of times your nose and your mouth per hour. It will also lead to less spread of aerosols and droplets by the one who wears this face mask. And there is also some filter function which depends very much on the type of face mask. Now I will give you some truisms, or as the Dutch call it, a truth as a cow. A contribution to less spread. If there is no disease present, it has no contribution, of course, at all, of course, these face masks. If you are with 10 people in a space and they are all wearing face masks, but nobody is contaminated with the coronavirus, it has no additional value, of course. And if you all are on the beach and you have 100 meters of distance, there is no contribution as well of this face mask. And if you do not appropriately wear the face mask, it will also have hardly any contribution to the prevention of COVID spread. And if you have very bad masks, there will be no distribution either. And all the beneficial effect of a mask can be undone if you do not take other hygienic measures. Now here you can see the effect of wearing a mask where the air goes, and I can refer you to this small YouTube video. And I think the picture speaks for itself. And if you look at these different situations, if you have no mask, and you can have a look of what is happening when you sneeze. As you can see here, there is a lot of aerosols is spread. But when there is a cloth mask of one layer is worn, you can see there is already far less of a spread, and when there is a cloth mask of 2 layers, there is even less spread, and a surgical mask will reduce it even further. Well, there is a lot of discussion about whether the mask will work, yes or no. Well, we know in the ICU and in the operation room that these masks simply work to prevent disease. We have taken care of patients with COVID, and we have not been contaminated. But it only helps when you wear them well and if they are of good quality. Now, why do respected scientists say that these masks do not work? And the Dutch CDC, the RAVM, was opposed for a very long time to face masks to be worn in the public space. And it depends very much on the definition of evidence. It's very easy to say there are no randomized controlled trials, and therefore there is no clear evidence that they will work. Another important problem that is not really addressed is the quality of the non-medical face mask. There is, as far as I know, no legislation on that. Now, related to randomized controlled trials or clinical trials, this is a study that was published in 2019 about the FFP2 mask versus medical mask for preventing influenza among healthcare personnel, and it was a randomized clinical trial. And what they saw is that there was no difference in the number of contaminated healthcare workers. But personally, I do not think that this is a kind of study that will give you definitely the information whether the FFP2 mask is better than the just surgical mask, because I have shown you the pictures of the way that these masks really work, and then you can see that there is less spread of that there is more air is filtered. And in such studies, you still can get contaminated outside the hospital. There was no check whether the masks were really well worn, etc. So this trial, although it said that this trial resulted in no significant difference in the incidence of laboratory confirmed influenza, it is not necessarily the truth. And I prefer to look at it in a mechanistic way. And this is another study published in 2009 among nurses in Ontario tertiary care hospitals. Use of a surgical mask compared with an N95 respirator resulted in non-inferior rates of laboratory confirmed influenza. Again, the same problem. People can get contaminated outside the hospital, can contaminate it in other situations in the hospital. They can wear the mask not very well. So there are a lot of confounders So I do not think that these kind of trials will give us the answer, and I urge that we mainly look at the mechanistic ways that these filters may work. Now, I have a bias, of course, because I really disagree with the too strict of evidence-based medicine, as it is called, but they mean in fact randomized controlled trials reasoning. I think that randomized controlled trials cannot provide answers to all relevant questions. There are too many biases like design, confounders, and not everything that is relevant can and will be measured, and that we have shown in several studies. But it was this feeling that made me think of this study that I designed, the effect of small versus large clock size on emergency response time, a randomized controlled trials. And this is in one way a serious trial, and of course it's also a trial to be a little bit to protest a little bit about the value that is so much attached on randomized controlled trials. What we did is very simple. We compared 38 size clocks versus 47 size clocks in the running a specific distance, whether you would run faster with 38 size compared to size 47. And we randomized a group of our nurses and doctors working in the ICU to run to an elevator where you would go in case of a situation of resuscitation. And you can see here our table 1 with the characteristics of the participants, and this is how this study was really done. So clocks could be too big or too small, as you can see here, depending on how the size of your feet are, and of course to which size you were randomized. And we also did a proper statistical analysis, as you can see here, to see whether gender, age, height, own shoe size, fitness and star function would play a role. And as you can see in this figure is that in fact the size 38 clocks showed a faster time. So the conclusion is that European size 38 clocks lead to faster emergency response time than size 47. So when your reasoning is that you only think in randomized controlled trials, well, people should now, everybody now should wear size 38 clocks, because this is the only randomized controlled trials on clock size. There is an evolution in the face mask, and this comes from a recent German site of Baden-Württemberg, where they say that FFP2 masks are now present for teachers, and also in nursing houses and for homeless people. So I come here to the end of my presentation, part 3, and I invite you to have a look at part 4, where I will discuss drug therapy in COVID-19. Thank you very much for your attention.